As we continue with today's scientific sessions, we now bring to you the Gut Intelligence Quiz, where knowledge meets intuition and the smartest guts win. This quiz will challenge your clinical instincts and test your gastroenterology and hepatology knowledge. Get ready for exciting questions in a fun and competitive spirit. May the best gut win. May I call upon our quiz master for today. Dr. Prachi Karnik is an additional associate professor, Department of Pediatrics, LTMGH, and she is also the in charge, Division of Pediatric Gastroenterology and Hepatology at LTMGH. Welcome, ma'am.
Thank you, Aditi. So as we come to this quiz at the outset, I would like to put on record that two of my colleagues, Dr. Aditi Dharap, who was a lecturer with us in gastroenterology just till recently, has helped me with the quiz to prepare the first draft of the quiz. And my fellow, Dr. Rutuja Badge, who's on stage with me, has been the entire technical support for this. We have already put up all the rules for the quiz on the group, and we have put up the QR code as well and a link. So all of you, those who have not yet done, can still go to kahoot.it. It's not in, it's it. And once you go there, you will be able to, have to enter this game pin, or you can also scan the QR code that is given there. While you all are doing that, Dr. Rutusha will tell you the rules of the quiz once more quickly. And we request you all to put your full names, please, so that there is no challenge in deciding who's the winner in case you all are sharing your initials. We have 3 prizes also at the end of the quiz. Rutusha, can you tell them the rules?
Yes. So, welcome to our gut intelligence quiz. First of all, please take out your phones or tablets and go to kahoot.in. You can access the link via the link which is provided in the WhatsApp group. You will see the question on the main screen and the answer options on your device. You have to tap the shape or color that matches your option. There will be 15 questions. 30 seconds will be given for each question. Speed and accuracy
There's one
matters.
group of delegates,
Kahoot
or you can
rewards
just
you.
scan it right now, ma'am.
Kahoot rewards you for answering correctly and quickly. Faster answers get more points. Once you tap your answer, it is locked in. There is no negative marking, but no changing your answers either. Make sure your internet is stable. However, if you disconnect, you can rejoin anytime using the same game pin and the leaderboard updates after every question. You will see a leaderboard podium displaying the top 5 participants, and at the end, we will announce the top 3 performers. The winners will be given exciting prizes. I will just show you a demo quiz so that you have a better understanding.
Rutuja, I think just wait for the demo. Some people are still trying to log in. We'll just wait for 2 minutes. Ma'am, anyone needs help, we'll come down and help you.
Currently, 53 participants have joined.
You can just go to Google and type kahoot.it, and you will be directed to the website. Sanya, just help ma'am, no? No, Mangalani ma'am. So while we start, I'll again quickly tell you what we're going to do. There are going to be 15 questions here. The timer starts as soon as I start reading the question. So I'll take about 15 or 20 seconds to read. You will get 10 to 15 seconds to answer. Okay? You will be able to see the options on this screen, and on your phones you will have to select the color that matches the color of the answer. The right answer will get the marks, but if there are many people who have given the right answer, the one who has done it fastest will get more marks. So that is how the app itself will calculate the marks. There's nothing in our hands. So we'll show you a small demo with 2 or 3 questions.
So for the demo quiz, I'll enter the pin as shown.
This is a demo, you all don't have to enter this. Look at this screen, this is what you all are going to do.
So this is how the question will appear.
So you all will be seeing the main question first because that's the format in the thing, and the detail of the case will come later. This will be the 4 options, and what you will see on your mobile is this screen. You will just see the red, blue, yellow, green color. So deciding upon the correct answer there, you have to mark accordingly on your screens. And then the first 5 top, the people who get the top 5 marks will be displayed on the screen at the end of every question.
This is the second question. 30 seconds will be allotted for each question. For example, if you want to answer option 3, which is autoimmune sclerosing cholangitis, then you'll have to tap on yellow colored, which corresponds to 0 figure, circle. And it will show whether it is correct and how many people have answered correctly. Should I start?
Yeah, so the idea of this is, of course, to have a fun quiz, but also to give you all some takeaway points, 1 or 2 takeaway points per question, and then we go on to the next. So shall we start? All of you are ready?
62 participants have logged in.
You all can join in between also in case somebody walks in, your friends, neighbors, you can tell them to join in. The marks will, of course, may not match, but that's fine. Yeah.
So I'm starting.
So this is a 12-year-old girl who came with recurrent hepatitis since 7 years of age. Along with jaundice and firm hepatosplenomegaly, she also had some thyroid swelling. The bilirubin was high, AST, LT, there was transaminitis, low albumin, and the TSH was elevated with a free T3, T4 low. Which set of investigations would you prefer to do first? So the correct answer was ANA, ASMA and anti-LKM along with total IgG. Most of you have answered it correctly. It was a simple case of autoimmune hepatitis. The takeaway point here, there are 2 things. One is that whenever you have a multi-system disorder or an autoimmune kind of picture, always look for other systems. We have ourselves seen many patients who came as alopecia areata and then some mild derangement of LFT, they turned out to be autoimmune hepatitis. Many of our type 1 diabetes, many of our IBDs have an associated autoimmune hepatitis, so, and thyroiditis, of course. Other than that, what we have written here is total IgG. So many of these patients of AIH, they may not have a anti-LKM elevated or an ASMA elevated, but a total IgG high will give you a clue towards an autoimmune hepatitis, and you can start treatment just based on that. So always order for total IgG along with the rest of the panel. Next question. So this is a 10-year-old girl, known case of type 1 diabetes, and she went to the nutrition OPD for refractory anemia, referred to us, had pallor, stunting, abdomen was mildly distended, and these were her upper GI endoscopy findings. I'll describe them to you. You're seeing some fissuring, and you're seeing scalloping of the edema. The wavy pattern of the mucosa is scalloping. So which investigation should be ordered next? So yes, most of the people again had answered correctly. The takeaway point here is that do not ever order only the TTG IgA, always with the total IgA, because in a case of IgA deficiency, you may falsely get the total IgA low. Some of you, I think, had answered EMA also. The thing is, EMA is highly specific, but many times can have a lot of false positives. So always go by the TTG IgA first and then the biopsy. Next question. This was a 20-day-old full-term infant, non-consanguineous marriage, jaundice since day of life 15. He was well-grown, non-sick. These were the stools that were present, had a firm hepatomegaly, which should be the investigation to confirm the diagnosis. Yes, so we have a lot of people still saying HIDA scan and an abdominal USG. Those who said abdominal USG may not be entirely wrong, but our question was for confirming the diagnosis. So USG will never give you a confirmed diagnosis. And this is why we put up this question. We want you the takeaway point that HIDA is not really a good, any more recommended test for this. Because even if your HIDA is non-excretory, it could be things other than biliary atresia also. And for doing the HIDA, you have to give 5 days of phenobarbital. After that, you have to do the HIDA, then the 24-hour scan, you're wasting a whole week. And every day wasted is a poor outcome for a biliary atresia child. So liver biopsy from a good histopathologist with the result available in 2-3 days is the gold standard that is currently to be practiced. Next. A 10-year-old girl who came with severe epigastric abdominal pain. It was a typical pain with relief on bending forward, multiple episodes of vomiting, had epigastric tenderness, and her serum amylase lipase were elevated. USG abdomen was at this point awaited. Now what will be your management strategy at this point? Yes. So good that we have taken up this question. Most of you have said that the child has to be kept NBM till the abdominal pain and vomiting subside. That's not true. The current guideline says that you have to start enteral feeding as early as possible. That will reduce the chances of superadded secondary infections, pancreatic necrosis, and a whole lot of early complications. The only criteria is the child should be able to tolerate it. So for the pain, if it is mild, you can give simple analgesics, but ensure that the feeds are started as early as possible. Next. One-and-a-half-year-old boy who came with intermittent painless passage of dark blood in stool since 6 months. No crying, no irritability, did not require blood transfusion, was well grown, and there was no abdominal distension or tenderness. The HB was low. Other than that, the stool showed RBCs present. All the radiological investigations, USG, CT, angiography, as well as a colonoscopy and biopsy, all that was normal. So which diagnosis will you consider? Okay, so cow milk protein allergy, we have done a colonoscopy for this child. We have done a biopsy also. CMPA will not be missed on these investigations. Meckel's is the correct answer. Although the CT abdo with angio was normal, only 45 to 50% of the times the CT will pick up a Meckel's. The rest of the times it can be missed. So you have to do a technetium scan because 90 to 95% of patients will be picked up on the nuclear scan. Yeah. We had a 5-year-old boy with jaundice since 10 days, abdominal distension and encephalopathy for 2 days. Had a firm hepatosplenomegaly. I want you to pay attention to the labs here. The HB was low. The transaminitis was present with the AST markedly elevated as compared to ALT. ALK phos was significantly low as compared to bilirubin. So what do you think is the probable diagnosis? So many of you have answered correctly, Wilson's disease. The pointer here was an anemia, which in Wilson's, especially when they present as an acute liver failure, is known because of the copper toxicity, because of which, again, because of that hemolysis, the AST will be markedly high as compared to the ALT. And also the ALK phos in this case, because it is not generated well in the liver in Wilson's disease, is significantly lower. Whenever you have cholestasis hyperbole, the ALK phos you expect to be high. But in a child with Wilson's disease, the ALK phos will be significantly low when you compare it with the bilirubin. There are some ratios given, right now not going into it. Next question. A 6-year-old boy born of second degree consanguineous marriage with jaundice for 6 months, pruritus for 5 months, and some ecchymotic patches over his body. Significant history of death in elder sibling due to liver disease and pruritus in mother in both the pregnancies. There's icterus, ecchymosis, scratch marks, and firm hepatosplenomegaly. So what investigations may give a clue to the diagnosis? Yeah, so basically here we are dealing with a case of PFIC because there is a history of cholestasis in mother during pregnancy. There is a history of liver disease in the child, and there's pruritus. Whenever you have a combination of cholestasis and pruritus, you have to consider PFIC as a strong possibility. Many of you might have marked low GGT because PFIC is classically said to be a low GGT cholestasis, but that is for newborns and infants. But when you come to older children where we are considering PFIC 3, you will have a high GGT. This is a knowledge-based question. A 2-year-old girl is suspected to have very early onset IBD. So which of the following statement is correct? So this was only to sensitize you that there is an entity called very early onset IBD. Any child presenting below 6 years with IBD, you have to consider. Why is it important? It is a monogenic disorder most of the times, may be associated very often with immunodeficiency primary, sometimes autoimmunity, and the outcome will completely change if you do an NGS, prove it, and the child gets IVIG and or HSCT. So your usual immunosuppression will not work here, in fact should not be, because they will many times have immunodeficiency. So this is the reason we have put up this question. The next set of questions are image-based questions. A 6-year-old girl with fever, abdominal pain and weight loss for 4 months. The first are the skin findings. I'll not describe those. After that are the radiological findings, and there's something there in the iliac fossa. And this is the ileocolonoscopy, and whatever we have pointed, you all can guess what that is. So basically the skin findings were tuberculates, not very common, but this was one of our patient only, so they were tuberculates. And on the second picture, you could see some ileocecal thickening with a little pulled ups and deformed cecum. And the third picture of the endoscopy where we had pointed the arrows were all ulcers. They were all circumferential. This was the ileocecal region. And the IC valve also in this patient was very difficult to navigate because it was stricturous. So this was a case of abdominal tuberculosis. Eight-month-old boy with jaundice and pruritus, intermittent pale stools, the dysmorphism as seen, and on auscultation and ejection systolic murmur. What diagnosis will you consider? Look at the forehead, look at the nose, look at the chin. Clues. Yes. So it was a broad forehead with a bulbous tip of the nose and a pointed chin, triangular faces. The point I want to make here is this was still when the faces had evolved. But when you see these children in the early months, newborns, paraneonates, they will not have the typical faces. So you should not rule that out just based on the fact that there are no faces seen. Okay, we have gone on, sorry. 5-year-old boy with accidental consumption of drain cleaner and followed by burning, ulcers. This was the upper GI finding. I'll tell you that this is a circumferential involvement with a lot of deep ulcers. However, I'm not able to see any gangrenous necrotic changes there. So what should be my line of management? Yes, I think we moved on a little faster. Can you show them? You cannot show them. Don't move on till I tell you that you have to move on. Okay. No, so basically I'll just explain. This was, since it was a circumferential involvement, there was a very high, and it was deep ulcers, there's a very high chance of stricture formation. To avoid the stricture formation, we prefer inserting an RT, but it cannot be done blindly without an endoscopy because we'll end up perforating. So during the endoscopy, under vision, we put in an RT, keep it, and then after 4 to 6 weeks, we do a barium and see if there are any strictures, and then we dilate them endoscopically. And this child will have to be kept NBM for some time because of the circumferential involvement. If it is not circumferential, then you are safe to start the child on feeds once he starts tolerating, very slowly, like we increase after any surgery. However, if there are necrotic changes, then keeping NBM is an essential thing. So this was a 15-month-old child with steatorrhea. These were the eye findings, a peripheral smear, and the biopsy. Yes. So hemat and GI go hand in hand. Yes, so this was quite a simple case. Most of the residents also luckily have identified the acanthocytosis, so their hemat as well as GI is very strong. The last thing what you saw in the biopsy were fat-laden intestinal cells, enterocytes. And first was, of course, vitamin A deficiency. Next. an 11-year-old girl with recurrent abdominal pain for 4-5 years, and there is also inadequate weight and inadequate height gain. There are bulky, foul-smelling stools that are difficult to flush. This is the X-ray. We have given the pointers to some of the findings. I don't know if they are very clear from there. Okay, I'll say there were some radio-opaque spots where the arrows are marked. That much I can tell you. Yes, so basically wanted to tell you about the fact that steatorrhea should not be missed. How do you ask? This is for residents. How do you ask for steatorrhea? Is bulky stools. Now, what do we mean by bulky stools? You compare the quantity of the food that the child eats as compared to the quantity of stool that he passes. So that is bulky. They are foul smelling, and if it is a Western commode, they will float on water. If it's an Indian toilet, they'll be difficult to flush out. They'll stick to the pan. So this history, along with a failure to thrive, will point to you towards a fat malabsorption. Next. A 5-month-old girl with chronic diarrhea for 4 months, anasarca, and a history of inadequate weight gain since birth. And then she had these asymmetric limbs. If you look at her upper limbs, they were asymmetric. And she had hypoalbuminemia, very significant. And rest of the findings were normal except for gross ascites. Even her UPCR was only 0.2. So what is the most probable diagnosis? This was her endoscopy findings, snowflake appearance in the duodenum. Yes, primary intestinal lymphangiectasia. So always think of this cause. Whenever you have a chronic diarrhea with anasarca, ascites, and hypoalbuminemia, you've ruled out a renal cause. Always look for a GI loss of the protein. And your any lymphatic malformation anywhere else in the body will point towards a PIL. I think we are on the last question. Four-year-old girl with recurrent transfusion-dependent anemia, sir, hemat again, starting at 1 year of age, HB dropped up to 3. She came with severe pallor, stunting, wasting, no other bleeding manifestations, no jaundice, no organomegaly, no bony, cartilaginous or subcutaneous swellings. This was on the sole of her feet and a lot of other places on the skin, and these were the scopy findings. So this was again a patient referred to us. This case again, because whenever you have an anemia which is refractory and all the hematological investigation has been done, nothing is found, it can still be a case of occult GI bleed. So please refer to gastroenterologist, get a scopy done, if required CT angio done, and you will get the answer. This was our own patient. We had started her on sirolimus, which is the treatment of choice for this blue rubber bleb nevus syndrome. After 8 to 9 months, she has become totally no blood transfusion required again. We have repeated her scopy. Her lesions have markedly reduced in number also and in the size also. So a right referral at the right time can really save a patient. So I think we are at the end of the quiz. I had to hurry through it because we are already running late. So the third prize goes to Akshata Gauri. Akshata, come. We have prizes for you. Second, Devina. Dr. Devina Datta. And first prize, Dr. Srihari. I hope you all enjoyed the quiz.
Srihari.
Thank you, ma'am, for this fun and engaging quiz. I would like to request Dr. Sadhna to present Prachi ma'am with a token of our gratitude.